And to kind of follow up, as Dr. Kamani said, now we're going to be shifting gears a little bit. We're going to be talking about the future of steroids and where we're at within the vasculitis community on the future of steroid use and the horizon for steroid replacement. And for this conversation, we're going to have Dr. Jason Springer. Dr. Springer completed medical school at the University of Louisville and his internal medicine residency at the University of Utah, where he was mentored by a vasculitis specialist, Dr. Curry Koenig. He completed his general rheumatology and vasculitis fellowship at Cleveland Clinic. After his fellowship, Dr. Springer went on to the University of Kansas Medical Center, which I know very well, where he developed a vasculitis center. He remained there for 7 years. Most recently, he started a position as co-director of the Vasculitis Center at Vanderbilt University Medical Center. Dr. Springer, welcome.
Thank you. Can you hear me okay? Is my mic working? If somebody can confirm. Excellent. Okay, good. So yeah, thank you, Sarah. Sarah and I share the fact that we're both Chiefs fans. So we're both happy with the way the season is going, I think. But anyway, so Dr. Kermani gave a great lecture on the basics of steroid use. And so we're going to delve into this a little bit more. We're going to talk about what does the future hold for steroid use? So how can we potentially minimize steroids or even replace steroids? And so these are my disclosures. So I have served as site investigator for some of the studies that we'll discuss today. And as Dr. Kermani had mentioned, steroids is actually a broad term, and I think it's important that we nail down the definitions of what we're talking about. So steroids are a bunch of different hormones that share this four-ringed structure. You know, there are sex hormones like estrogens and testosterone and anabolic steroids. We're not talking about those steroids. There are mineralocorticoids, which help you regulate your blood pressure and your electrolytes. We're not talking about those steroids. What we're talking about is glucocorticoids. And so that includes things like cortisol, prednisone, methylprednisolone, and others. And so for the purpose of this lecture, when I say steroids, I'm actually talking about glucocorticoids. So when we talk about eliminating or minimizing steroids, I think there's two perspectives. There's a patient perspective. So many patients share in common that they have been on steroids in the past and have experienced some of the side effects related to steroids. And so for many people, I think they're ready to get rid of the steroids. And then there's a physician's perspective. And from the physician's perspective, it's maybe a little bit nerve-wracking thinking about eliminating steroids. Now, this is from a study that actually looked at patients' perspectives on steroids and what they experience, and put into basically a word cloud. And many of you are very familiar with these side effects. So irritability, weight gain, insomnia, moon face, skin changes, increase in blood sugars, GI issues, and many, many more. So given all of these side effects that you can experience with steroids, why are physicians so reluctant to give up the steroids? Well, I think there are several reasons. So for one, it is an older medication. So it's, quote, stood the test of time. They're also very fast acting. So the onset is within hours instead of, for many of our medications, it takes days, weeks, or even months to really see the full action of the drug. Also, these forms of vasculitis are potentially life or organ threatening. And so we do have a low margin of error at times. And so we want to make sure that we're getting it right. And for some physicians, including myself at times, I fear the disease more than the side effects from the medications. But we're in a new era now, and the treatment for vasculitis has changed fairly dramatically over the last 30 years, but especially in the last 10 years. So as you've heard from other speakers, we have new medications in many different forms of vasculitis, some that never had FDA approved medications before. So we'll talk about some of the strategies here. We'll talk about where we are now, and we'll also talk about some of the things to expect for the future. So one strategy is to minimize the amount of steroids that we use. And this really isn't a new concept. So as Dr. Kermani had mentioned, cortisol, or cortisone, I should say, was was discovered in the 50s. And shortly thereafter, people really knew that there was a lot of potential side effects with steroids. And so from there on out, people not just in vasculitis, but other forms of vasculitis, looking at using other medications to minimize those steroids. And I'm going to give you an example in GPA and MPA in the efforts to reduce steroids. And so if you look at these diseases in just treating with steroids, what you see is, you start out treating with high dose steroids. And then as you taper, if you don't have anything else in place, what classically will happen is there will be a relapse that occurs and the disease comes back. And then you have to go up to high dose steroids and try to taper again. And this just cycles over and over again, typically. And so it really wasn't until the 1970s when Dr. Fauci and colleagues at the NIH started treating with cyclophosphamide. And then all of a sudden, patients were able to sustain a remission. And these relapses were less common. And so there was less steroids being used. And so from then on out, other medications came about. So in 2005, methotrexate was shown to be effective in non-severe disease. In 2008, methotrexate and azathioprine, you saw some of these results earlier, was both shown to be equally effective as maintenance therapy. 2010 is when rituximab came about and, was approved anyway, as an induction therapy, which was just as good as cyclophosphamide at putting severe disease in remission. And then there's mycophenolate as a maintenance therapy. Also, some people have looked at as induction therapy. And also rituximab here recently has been looked at as maintenance therapy. And this is the first, Ritson's one study was the first study that came out, but there's been many others that have come out since that time. But all of this effort has helped us to reduce the amount of steroids that we use by utilizing these other medications. Now, the steroid taper that we use is something that's been kind of handed down, but it really hasn't been heavily scrutinized until here recently. So this is a study that actually was published this year, and it's called the Pexavas study. And what they did is they looked at our typical steroid taper, and I showed that here. That's the brown line on the top in a typical 70 kilogram person. So it's not uncommon for us to start around 60 milligrams of prednisone per day. Sometimes we go a little bit higher. And then we have this very slow taper, and we try to aim for getting down to about 20 milligrams by 3 months. And then by the time you're getting to 6 months and you're getting to 5 and less. And so what they did is they compared this to a more rapid taper. So in this study, these were patients that had severe disease. So they still wanted to start out high. So they started at 60 milligrams per day. And then they tapered a little, they tapered a little bit quicker. So by 1 to 2 months, they were at 20 milligrams per day. And then by 3 months, they were getting to less than 10 milligrams per day. And so you can see there is a big difference in terms of the prednisone exposure between these two groups. I also want to point out that we do know that the risk of side effects from steroids is really dose dependent. So those higher doses is where you're more likely to get side effects. Whereas when you get down to lower doses, such as 10 and below, the risk of those go down. So these are the results from the Pexavas study. On the left is looking at a composite of death and the probability of going to dialysis. And so a higher number is worse, so you want a lower number here. And they compared that standard slow prednisone taper to their reduced faster taper. And essentially there was no difference in terms of this. And then on the right here, I showed some of the other outcomes. I included some numbers here for those of you that are interested, but they compared the two in terms of sustained remission. There was no difference. They compared the two in terms of severe adverse events. Again, no difference. And then but what's interesting is there were less severe infections at 1 year in the quicker taper of prednisone. So, you had all of the benefits of controlling the disease, but less infection. So I think this study really kind of opened our eyes in terms of really critically analyzing the tapers of prednisone that we're using. Another study that is ongoing right now is the Abrogat study. This is a study that's looking at non-severe flares of GPA. And again, on this graph, I've showed you our typical prednisone taper, and below that is a taper used in this regimen. Now, these patients do not have severe disease, so they felt comfortable going with a lower dose at the beginning and then tapering from there. And again, you can see there's a big difference in terms of the steroid exposure, especially at the beginning. And again, this study is ongoing. So we've looked at GPA and MPA. I'm going to also give you some example from giant cell arteritis in our journey to try to minimize the steroids. And so giant cell arteritis was described in the 1930s by Dr. Horton and colleagues, where they described some cases. Remember in the 1950s when the Nobel Prize was given for the discovery of cortisone. And so shortly thereafter, they started using it in giant cell arteritis. And from there, people started looking at the other medications to try to minimize that. So in 2002, methotrexate, which really didn't clearly show a benefit. 2007, infliximab, 2014, adalimumab. And then also in that year, there was a big study looking at all those studies and really didn't show a clear benefit in any of those other medications in terms of reducing the steroids. And it really wasn't until 2017 when the GIACTA study came out looking at tocilizumab. And so this is kind of a layout of the GIACTA study. So they have 4 groups, and I've labeled them A, B, C, and D. And B is what our standard of care was to that point. So this red triangle represents our prednisone taper, and you can see it's a very long taper. It goes all the way up to 52 weeks. And then also the rectangles here represent if there's any other medication. So in this group, they got placebo. So they only got a long prednisone taper, similar to what we were doing. Group A got a shorter prednisone taper over 26 weeks, and again, did not get anything else. And group C and D had that shortened taper and then got tocilizumab either in weekly injections or for D, it was every other week. And they evaluated things at 52 weeks. And so this shows the groups, and on the y-axis here is patients without flares of the disease. And so a higher number is better. And so the yellow is the quick taper of prednisone without anything else. And so they did the worst. The blue is kind of what we were doing before this study. And so, did better than the quick taper, but not great. And the other lines, the purple and the green, are the ones that got tocilizumab with the short prednisone taper. So did much better and limiting the amount of steroid exposure. So based on this trial, the medication was FDA approved for giant cell arteritis, and it was really the first FDA approved medication we have for giant cell arteritis. So the other strategy we can look at is replacing steroids. And so how do you replace something that's so ingrained in our culture? Well, this painting, by the way, is in the Prado Museum. As many of you know, the Mona Lisa is not in the Prado Museum. This was actually thought to be done in Leonardo's studio at the same time because some of the changes are the same as the Mona Lisa. And so this gentleman is essentially making a copy of what is a copy. So what are the requirements for replacing steroids? Well, there are several things. We need to make sure that it's working, that it's controlling the inflammation and the disease. We also need something that's going to be fast acting because steroids are quick acting. We need something that's going to be easy to use. So we don't want to have to admit people to the hospital to have to give it. We also want something that's going to be compatible with some of the other medications we use, like rituximab and cyclophosphamide. And we also want something that's going to be accessible. And then I'm going to go through a story of steroid replacement in GPA and MPA. And this is a story that's really going to take us from the bench to the bedside. So this summarizes some of what we know about how the disease propagates. And it's kind of a busy slide, but I'm just going to point out some things here. So on the bottom here, this is the blood vessel wall, which is lined by the endothelial cells. And I want you to focus here on the complement cascade. So the complement cascade is part of our immune response. And we know that part of the complement cascade, the C5a, plays a role in the disease. What it does is it actually binds to a type of white blood cell called neutrophils, and it binds via this little receptor. And when it binds to this receptor, it makes the neutrophil mad. And when the neutrophil is mad, it starts wreaking havoc on the blood vessel wall and thus propagating vasculitis. And so knowing this, investigators looked at whether they could actually block that interaction with C5a and its receptor on the white blood cell. And this is in mice that develop similar vasculitis in the kidneys to GPA and MPA. And I want to actually point out the year of this. This is 2014, only 6 years ago. And so in this figure, crescents, that is a measure of inflammation in the kidneys. So a higher number means there's more inflammation in the kidneys. And so in their mouse model, you can see there's inflammation in the kidneys, and they gave this medication that blocked C5a from its receptor, and they gave a little bit and there was less inflammation. They gave a little bit more and there was less, a little bit more and even less. And at a certain dose, there was very minimal amount of inflammation. And what this medication is called is CCX168, which is essentially the precursor of what would become a Vacpan. So this led to the Vacpan trials. So a Vacpan is a C5a receptor inhibitor, again, blocks that interaction with C5a and its receptor. It is an oral medication, and they are focusing specifically on GPA and MPA. And the reason is because we know that C5a plays a role in these diseases. And so the phase 2 studies have been completed. There were 2, the CLEAR and CLASSIC trial, and they demonstrated this medication to be effective and safe. And I'll give you some highlights of those. What was kind of radical about these at the time is that they had steroid-free arms, which hasn't really been done. So in this figure, this is the percent change in the disease. So as a lower number is better. And the groups are high dose steroid, in addition to, rituximab or cyclophosphamide. That's the black line here. The red line is a Vacpan with no steroids. And then the squares here are the Vacpan with low dose steroids. And what you see is the Vacpan groups did better than using just steroids alone, even when there was no steroids. As far as adverse events, there were a similar number of adverse events between the groups, but the patients that got a Vacpan had less of the steroid-related side effects. Now these figures show E is the physical functioning, F is emotional functioning, and G is kind of an overall functioning. And all this is derived from the patient data, so the filling out forms. And so you can see here that the Vacpan with no steroids group, which is a red, did the best in each of these measures. And by the way, a higher number is better. So this led to the phase 3 study. So a phase 3 study is typically the last step that if it's successful, then the FDA will potentially approve it. And so for phase 3 studies, they like that we compare to what is the standard of care at the time. So that's the control group here. And so in this study, they are giving patients, all these patients have severe disease. They're giving either rituximab or cyclophosphamide as we normally would, and then a prednisone taper, starting out high and that slow taper like we talked about before. And then they'll give something that looks like a Vacpan, but really isn't, so a placebo. And there's 150 participants in that arm. The other arm is a study group where, again, they get rituximab or cyclophosphamide, and then they get something that looks like prednisone, but really is not. And then they get a Vacpan twice daily. So their outcomes in this was remission at 6 months, but also they wanted to make sure people were able to sustain that remission at 12 months. So the phase 3 study has been completed. There have been reports that it was a positive study, but the data has not really been published yet. So the general medical community hasn't really had a chance to pour through this data. But the FDA has looked through some of the data and accepted a new drug application as of September of 2020. So that's encouraging. Also, what's come about is another pharmaceutical company has taken interest in this and have actually developed another potential medication to target C5a directly. This is in phase 2 studies, which is being done in Europe. So where are we now? Well, we have a feasible steroid replacement in GPA and MPA. Unfortunately, that doesn't mean we have a steroid replacement in other forms of vasculitis. So different forms of vasculitis have different mechanisms that the disease progresses. And so, it's likely that this isn't going to be the replacement in all forms of vasculitis. Now, that being said, eosinophilic granulomatosis with polyangiitis, or Churg-Strauss, has some similarities in terms of the pathogenesis to these diseases. So it'll be interesting to see how it plays out in EGPA. But what we do have in the other forms of vasculitis is proven medications that minimize steroids. I gave you an example in Giant's arthritis, but that's not the only form of vasculitis where we have found medications that help reduce the steroid burden. So what does the future hold? Well, a Vacpan, it's looking encouraging that that's going to come out, but it'll be an expensive medication, and prednisone is cheap. And so I suspect that initially we're going to have a struggle with insurance companies to use a Vacpan, in terms of demonstrating to them that it is useful to use. But I think that all of this has opened the eyes of physicians and made us more willing to contemplate that we could try to minimize our steroids or potentially use no steroids alone. Obviously, we need to take into account patient factors in this decision. Also, I think scientists are now more interested in looking at these unique targets in other forms of vasculitis. There's also, I imagine there's going to be recognition by funding agencies that there is a need to support vasculitis-related research so that we can support maybe the Vacpan of other forms of vasculitis. And we're already seeing that pharmaceutical companies are interested in trying to find these medications as well. So unfortunately, I can't tell you that we've replaced steroids in all forms of vasculitis, but I think the future is bright. And I think we have to continue thinking big, but taking that small steps to get to the goals we want. And so with that, I'll end. This is a picture of my son as an infant there. So hopefully I didn't put you to sleep like he's doing here. Thank you.
Oh, well, thank you so much, Dr. Springer. I appreciate it. We did have a couple of prednisone questions on the Q&A if you wanted to check those out and kind of weigh in on those. But thank you. It's so good to hear that there are things on the horizon for sure. So thank you so very, very much. And go Chiefs.
Yeah, go Chiefs. Tomahawk.
I know, right? Okay.